All right. Good morning, everybody. Welcome to Comparative Ocular Pathology Lab Rounds. It's fine morning, June 10th. I'm Jamie Miller. I'm one of the staff pathologists here at Coplow, and I'm going to get started with our first two cases. Let's the PowerPoint. Go. So I don't have a gross photo for this first case, but this is we got an evisceration sample from the left eye of a about 7.5-year-old female spayed Pomeranian poodle mix. This dog has a history of bilateral retinal degeneration since November of 2020, so going back a little ways. It's a little bit of an older case. They did note that cataracts developed in both eyes in July of 2022, and that the one in the left eye, the cataract progressed, and they suspected acute lens luxation and glaucoma in that eye. And so they decided to do an evisceration sample. At the time, the other eye, the right eye, they just report the chronic retinal degeneration and an incipient diffuse cortical cataract. So the evisceration, they go in and they remove all the inner bits of the eye, leaving the scleral shell. And so that is what I have to show you. When we process evisceration samples, we like to make sure we note all the little bits that we get. So usually uveal tract, lens, retina. Sometimes there's still some vitreous that we can see grossly. And then we also note what we're looking at histologically, so we know what parts we had available for examination. Switch over. The mouse does not work. Okay. Let's see. This is the usual. Let's try to do something on this. Haha. So, when we get our evisceration samples, we usually do serial sections just to look at as much of the tissue as we can. So we have a couple of sections of lens. Here we have some pigmented uveal tract tissue. Here we can start to see some of the ciliary body plicae. There's a little bit of surgical hemorrhage, presumably here, and then these little fragments of this light pink tissue are retina, or at least what's left of the retina in this case. Right, so a little bit closer view. Again, here is our uveal tract. We have ciliary body plicae here. We've got some iris tissue. Here's some bits of retina that are just kind of all throughout. Here, or uveal tract. There's really not much in the way of inflammation in these pieces, which is good to note. And then if we take a look at our lens over here, we'll start over here. We have our anterior lens capsule that's a little bit thicker than our posterior lens capsule. And we can see from this low power here how we have some nice lamellar arrangements of our lens fibers, and then that kind of goes away and it gets all liquefied and degenerate back here. And if we zoom a little closer, we can see in our posterior lens capsule, we can see our lens epithelium has migrated posteriorly, which is usually one of the earlier signs of cataract formation. And then again, all of these liquefied lens fibers. And some of them start to round up and form these more Gagnian globules. And from lower power, we can see those changes in the cortex kind of go circumferentially around the lens. And then we also have a little bit of this deeply basophilic granular material within these liquefied lens fibers. And so we have some mineral accumulation here, which is another feature of cataracts that we can see. And so since this goes circumferentially around the lens cortex, in the Coplow world, we would call this a mature cortical cataract. Usually our cataract designations are not always correlated with what they're seeing clinically because we get usually one section of the lens, although in this case we have three because of the way that we sampled it. So it's a little bit different designation than, say, a clinical cataracts. Um, and then, like I said, our uveal tract is here. There was not any evidence of inflammation or membrane formation to account for the glaucoma that they did report clinically. They said the IOP ranged from 51 to 90, possibly due to the anterior lens luxation that they reported clinically, getting maybe a little bit of a reading from the lens rather than the globe. And then if we take a look at our fragments of retina, we can see that there's kind of a complete loss of architecture here. We don't really see any ganglion cells. We can't really see our nice inner and outer nuclear layers, and we don't see any of the photoreceptor segments. Oh, here's maybe one ganglion cell hanging on. Oop, here. So we have full thickness retinal atrophy in our sections. This could be due to the glaucoma, but again, remember that they reported bilateral retinal degeneration. And so it can be difficult when we get our samples when there's full thickness retinal atrophy to tell what's maybe glaucoma related versus maybe a primary retinal disease change, such as progressive retinal atrophy or which is PRA, or the sudden acquired retinal degeneration syndrome, or SARDS. But with their clinical history of bilateral retinal degeneration and then cataract formation, which can often occur later in the disease for PRA, it is suspicious that there's maybe both primary retinal disease and maybe glaucomatous changes occurring at the same time in this retina, which is something that we discuss in our morphologic diagnoses and our comments. The other biggest thing to note here is that there is no neoplasia seen, which is a big question for when you do an evisceration sample, because you want to make sure that there's nothing neoplastic that was maybe hiding in the eye and that could potentially be remaining and affecting the scleral shell. So, heading back to our diagnoses. So again, history of the bilateral retinal degeneration for about 2 years prior to the evisceration, with progression of the cataract in this eye, which we saw was a pretty decent looking cataract. With that full thickness retinal atrophy, again, with some differentials being one of the primary retinal diseases, and as well as the glaucoma as per history. So, as I mentioned, the cataracts can form in the later stages of PRA, and that's usually thought to be an endogenous toxicity that occurs with that. And so the degeneration of the rod outer segments may release water-soluble dialdehydes from peroxidation of the photoreceptor lipid membranes, and that can diffuse through the vitreous and kind of create like a toxic environment for the lens and the lens cellular membranes, and can damage the sodium potassium ATPase pumps and start to form the cataracts in the lens. So that's sort of the mechanism potentially behind that and why there is a cataract here with that retinal degeneration. And then my second case kind of springboards off of this one because it's a continuation.
So there's a question.
Yes,
here.
absolutely.
Jamie said, sorry if I missed, but given the chronic history, why is SARS still in the DDX? Or just one of those complicated cases we never fully know the answer? I think SARS in this case might be on the DDX just because of the morphology of it. We're not necessarily taking into account the clinical presentation. It's whenever we have a outer retinal atrophy, we cannot, morphologically or histologically differentiate between SARS, PRA, or other outer retinal atrophies for that matter. And we leave that to the clinician to work in the clinical presentation to make that assessment.
What was the breed?
A Pomeranian poodle mix. So I think poodles are a good breed for PRA and cataracts in general. Cool. All right. So, this eye, we actually ended up getting the entire eye, like 3 years later. So the dog was now 10 years old. When they did the evisceration sample procedure, they did put a intrascleral prosthesis in. And then they noted a few years later that they had some clinical changes that they were suspected to be nodular granulomatous episcleritis that had started, and that responded to steroids. And then about 6 months later, there was like another development of a lesion near the dorsolateral limbus that initially improved with topical steroids, but then it sort of enlarged and kind of created a little bulging area. So they decided to go ahead and remove the entire globe. They do note that the other eye still has the retinal degeneration, and that they had also done a chemical ablation at some point in the past. They didn't give a specific date, so I'm not sure if that was at what point that was done in the dog's history. So we've got the globe. That glass does not work. Put that one way over there. All right, so we have sort of the front view of the globe. So believe it or not, this is cornea, and you should be able to see through your cornea. It should be clear. You should be able to see inside, but in this case, it is very opaque. We've got a little bit of pigment sort of on the periphery here, and it's pretty solid. And this limbal sclera is a little bit irregular. It's a little bit bulgy, kind of where they were noting their findings clinically. And then a cut section of the globe. So we have cornea at the top here. We can see sort of the opaqueness and a little bit of pigment. This is not a defect or an artifact of the picture. This is what the intrascleral prosthesis looks like. It's like a black rubber ball looking thing. So the globe is very firm on palpation when handling grossly. And then the other thing that we note that in and around these prosthesis and in this chamber here, there's this like milky, opaque material that kind of fills the rest of the globe here. So we will take a look at that. So there won't be a whole much to see subgrossly. So here is our cornea at the top. It's looking a little bit bluer here, and we'll take a look at that. Usually that means that there's a little bit of hypercellularity to our tissues. And so we head back, and we can see that our scleral shell is missing our uveal tract, our lens, and our retina, consistent with their history of having the evisceration. Here is our optic nerve back here. And here's just another little extra radial section here. We do see a little bit of pigment still left here, and we'll take a closer look at some of these features here. All right. So we'll start up here with the cornea. So we have our corneal epithelium here on the left. It's a little bit hyperplastic, a little bit thickened. We get a little bit closer, we can see that there are blood vessels kind of throughout the corneal stroma, as well as some neutrophils. And our hypercellular area that we were seeing from kind of a subgross view is this aggregate of foamy polygonal cells, which are consistent with macrophages. So we have a little bit of a granulomatous or histiocytic inflammation here in the cornea. There's also, here's a little bit of that pigment in our corneal epithelium. And before I get to maybe the elephant in the room, I'm going to slide over to our other piece here. And so the other thing that we can notice is that deep in the corneal stroma is that we do not have any Descemet's membrane, aside for a couple little curled up fragments here that were left behind from the surgery. And what's covering sort of the inner surface here of the cornea, and it goes circumferentially around the scleral shell, is this dense collagenous tissue. Come back over here. Got kind of our limbal region here with our bulbar conjunctiva. And so we have some sclera. We've got some pigmented cells left over here, and here is our dense fibrosis. And then on the inner surface of that, going circumferentially around, we have this layer of epithelial cells. It ranged from maybe one layer all the way up to maybe like 8 to 10. And in some cases, it is stratified squamous epithelium. We've got our layers here, and that goes circumferentially around our scleral shell. So we have some intraocular extension of what's probably corneal epithelium that has grown into our scleral shell and has taken up residence and circumferentially surrounded what's left in this lining here. So if we head back, we can see here's our optic nerve. Looked pretty good. And then again, that lovely fibrosis that goes circumferentially around with our intraocular extension of our epithelium. And then the material that was left kind of in the chambers here is this sort of this amphiphilic, like granular, fibrillar, amorphous material with some foamy macrophages in here. So it wasn't really like a suppurative exudate, but it was just some sort of like a goopy material, possibly being secreted from the epithelial cells that are now lining the scleral shell.
Some of those could be keratinocytes too.
And yes, so some of them could be keratinocytes. So it's maybe not perfect for keratin, what we usually see with our keratin samples, maybe. So it could be just stuff, keratin and stuff sloughing off of those epithelial cells. Fibrosis, I think, is usually pretty typical for a scleral shell. And then we have that intraocular extension of the epithelium, which at some point may have caused a problem. So it's probably good that they got it all out. So most of the stuff at the top is a recap from the first case that I showed with the evisceration sample, and that they did the intrascleral prosthesis. And then we just have those different changes in the cornea, the inflammation and hyperplasia and pigmentation. And then most of this is what's expected from an evisceration surgery with, having an absent Descemet's membrane for the most part, and that intraocular fibrosis, and then having that intraocular extension of that corneal epithelium, which shouldn't really be there. And that material is either secretory or keratin stuff material that was filling the globe. So just kind of an interesting back-to-back progression of cases. Any other questions before I move on? Good. All right. I will make way.
right. This is Kelsey. I'm going to be doing the next two cases, starting with this eye. So this is the left eye from a almost 2-year-old female spayed domestic short hair cat. And the history received for this eye was there was an ophthalmos, thesis bulbi, an upper and lower lid entropion. They said no to glaucoma, and this has been going on for about a year. Remembering this cat's already quite young, so this probably started when the cat was at a very young age. Whoa, what was that?
No.
All right, little phantom line. So here is a picture of the heavy section of that globe. There's a little bit of Photoshop artifacts, so kind of ignore these areas. But what we had noted grossly, first off, there was not a recognizable cornea. So here's our little bulbar conjunctiva, and you can see that it continues over the anterior surface of the eye. Maybe down here, there's some normal cornea, it's kind of this yellowish tissue, but we'll look at that more closely histologically. In addition to that, our iris is broadly adhered to whatever this tissue is. So we have a broad anterior synechia with collapse of our anterior chamber. A lot of this is just ciliary body that's become kind of distorted due to that anterior synechia. It also looks like maybe it's adhered to this lens material here. This is not a normal lens. It definitely has a hypermature cataract, so it's kind of misshapen and it is very opaque. And then looking at our vitreous, there's all these kind of little tan strands. So this is real, this part's not. Kind of bridging from the back of the eye forward towards the back of the lens here. And there is technically an optic nerve head somewhere in here. It's just a little bit hard to see, possibly at this angle. And there is also kind of this tissue that's in the vitreous that might be obscuring it. All right, so we can move on to the histo. Starting with a subgross. There we go. All right, it's kind of nice, this small little globe, so we can kind of almost fit it in the whole screen here. So we have our optic nerve at the bottom here, and then our anterior segment is up top. If I can balance it, there we go. So clinically, they had diagnosed thesis bulbi, and we can also corroborate that looking at it both grossly and histologically. This does look to be a small globe. It's a young cat. But in addition to that, there's also kind of this wrinkling of the sclera, which is something we look for when we diagnose thesis bulbi. Looking at the anterior segment, similar to how we described it grossly, there really isn't much recognizable cornea. Maybe scooch this. There's a little bit of normal cornea at the periphery here, but most of it's gone, and instead it's been replaced by this tissue here, which is actually conjunctiva, and I can go closer to show that. So we have this broad symblepharon. And as we had seen grossly, here's our iris. It is broadly adhered to whatever is left of our cornea, but then also just directly to the conjunctiva here. So we have almost near loss of our cornea. There's been prolapse of the iris, and then just this symblepharon directly over that iris tissue. All of these little pigmented strands here and there are going to be the ciliary body plicae. As I mentioned, they're just kind of distorted due to probably this symblepharon and synechia. And then also there's this kind of collagenous tissue that's on top of the ciliary body and surrounding our lens. And we'll go closer to look at it. There's also this kind of weird, very brightly eosinophilic pink tissue associated with the lens or surrounding it, perhaps. This is our retina. It is detached. And then the back of the eye, we kind of just have this distorted choroid. Again, we can kind of look at it more closely. There's kind of some weird tissue on top of that as well. A lot of weird stuff to look at. All right. So the eye's now been rotated 90 degrees, so anterior segment is going to be to the right. Our optic nerve will be back here to the left. Let's maybe start with our normal-ish cornea. So here we have some normal corneal stroma at the periphery. We do still have Descemet's membrane as well. There is no corneal epithelium, so instead just the bulbar conjunctiva is totally adhered to the remaining stroma. So this is a symblepharon, as I had mentioned. As we go more axial, we lose Descemet's membrane, and instead kind of the termination of Descemet's membrane here extends over this adhered iris tissue. So we have a little bit of iris descemetization. And as we continue to follow this corneal stroma, this is kind of when we lose any stroma. There's kind of this dense fibrous tissue replacing it. And then it just completely becomes the bulbar conjunctiva. You can go a little more closely. Here's our conjunctival epithelium, and then this is our substantia propria. And then embedded within the substantia propria, there's also these little epithelial inclusions. Sometimes there's goblet cells. This is just conjunctival epithelium that's kind of become entrapped within the stroma here. We'll kind of continue to follow this. There's a little bit more of our conjunctival epithelium. And then I think, yeah, at the very periphery on the other side, we pick up more normal-ish corneal stroma. Here's Descemet's membrane again. And then up here also, we have more of those conjunctival inclusions within the substantia propria. All right. So we have a very distorted uveal tissue as we continue over this way. So here we're at our ciliary body pars plicata. And lining that, we do have this kind of more collagenous tissue, so a little membrane over it. And embedded within that, there's also this woven bone. We can go to other areas, kind of forming these amorphous structures. And then as we get closer to the lens, they're actually forming these more distinct trabeculae. In some areas, we have these intertrabecular spaces, almost resembling bone marrow. So we have adipocytes or fat, and there's all of these teeny tiny little cells resembling like little hematopoietic precursor cells. It's kind of a cute little finding. It's very well organized. I'm not seeing any atypia associated with the cells within that bone. So I would interpret this to be just a reactive osseous metaplasia or bone formation. As we look at our lens, go find somewhere where there's actually some lens capsule. Here's our thin lens capsule. If we follow it around, maybe we can make it out here. It gets pretty wavy. Here it is more. And then we have a discontinuation of that lens capsule. Kind of terminates within this little intertrabecular space. So we have a lens capsule rupture. And if we follow, kind of continue to follow it, we maybe pick up the other end over here. So here's that super wavy, wrinkled lens capsule. And this osseous metaplasia, so it's adjacent to the lens, but it also seems to be somewhat within the capsular bag itself. So here's the inner surface of that lens capsule, and we have that bone being laid down kind of against that surface. The capsular bag also contains some liquefied and fragmented lens fibers and just a ton of mineral and kind of more fibrous tissue. Okay, and then moving to the back here, here is our retina. Again, it's detached and it's also atrophied. So we do have some ganglion cells. We have our inner nuclear layer. There's not really much of an outer nuclear layer at this point, which is probably due to just chronic detachment. And then there's areas as we get more peripheral where there's just full thickness atrophy of that retina. In addition to that, there's also some mineralization of the walls of the retinal vessels, which could represent a dystrophic mineralization. So just tissue damage and necrosis, and you get deposition of calcium salts on that necrotic tissue. Sometimes we'll see with more metastatic mineralization, so calcium phosphate imbalances, so animals with renal insufficiency or hyperparathyroidism, things like that. In this case, they didn't mention anything in terms of medical conditions that might suggest metastatic mineralization, so I wonder if it's just a dystrophic or reactive change. And then moving over to our choroid, kind of a similar thing with what was happening with the lens. There's this collagenous tissue that's overlying the choroid, and also some osseous metaplasia within that collagenous membrane. And then just because we have it, with retinal detachment, especially in young cats, the retinal pigment epithelium will become hypertrophied and even somewhat hyperplastic. And we'll also maybe see these kind of like papillary formations coming off the choroid. So this is all hypertrophied and hyperplastic RPE, just due to the retinal detachment. And then lastly, we did not quite capture our optic nerve head in section. I imagine just with all of this distortion, it was maybe hard for our histo team to see it when they were making this slide. They did not mention glaucoma in this case, so I didn't think it would be prudent to go and try to get that optic nerve head. Our optic nerve looks relatively unremarkable in this section. So we have a ton of different lesions here. So in our anterior segment, biggest thing is we have this total near loss of our cornea. We have iris prolapse through that corneal defect, and then we just have a broad symblepharon overlying that, which is most suggestive of a condition that we call feline early life eye disease or feline early life ocular disease. The actual etiology to that is somewhat mysterious, but we suspect it could be a viral infection underlying it, especially feline herpes virus. And a lot of these cases will see concurrent symblepharon, as well as these little inclusions within the stroma, which can be features of feline viral keratoconjunctivitis. So it's possible just in the neonatal period, there was a viral infection that caused these lesions, and these are kind of the chronic sequela of that. Moving back, there's also some lesions that potentially we could attribute to trauma. So we do have a lens capsule rupture and a hypermature cataract. We also have retinal detachment and atrophy, as well as kind of this collagenous tissue that's being laid down. In animals that already have a blind eye, they are going to be less able to protect it. So it's possible this cat in the neonatal phase developed a blind eye, then at some point in life it bopped it and caused concurrent traumatic lesions. In young cats as well, we do always wonder, could this be a congenital etiology, which we often discuss and philosophize about at Coplow. In a lot of cases, it can be hard, especially when we have kind of these more chronic lesions, to say, was there also an underlying congenital etiology? So it's kind of a tricky case with a lot of potential underlying mechanisms to it. And perhaps I should have gone to my diagnoses as I talked about this. So yeah, just a long laundry list of diagnoses here. So I do suspect maybe we do have feline early life eye disease at the very least, just given how the anterior segment looked, and can't rule out there being some sort of concurrent trauma or even an underlying congenital etiology. In this particular case, they said the other eye was normal. So honestly, this distinction is perhaps academic as well, but it is fun to discuss and think about. And that is what I have for this case. Are there any questions, comments?
I have one comment.
Yes.
This is a great case to illustrate how the post-traumatic osteosarcoma
Oh, yes.
forms.
Thank you. I was going to mention that.
This is just such a beautiful case of like osseous metaplasia
Yes.
associated with lens capsule rupture, like cataract and lens capsule rupture, but it just takes one step further for that to become a tumor.
Mhm.
So it's really cool.
Absolutely.
Yeah.
Yeah, thank you. That was totally in my head to mention, and then I got all distracted. All right, great. It was a good one too, because grossly we mentioned that it felt very crunchy cutting into it. So we have a good correlate to that. Okay. My next one is going to be the globe. This is the right globe from an 8-year-old female spayed German Shepherd mix. And the findings they gave us, so this dog was referred to an ophthalmologist for irritation and inflamed upper eyelid after being treated for a corneal ulcer by the primary DVM. Exam by the ophthalmologist showed mild ventronasal strabismus with a large dorsal scleral mass displacing the globe. They specifically wondered about severe scleritis / NGE, which stands for nodular granulomatous episcleritis, versus some other cause of a scleral mass. They said no to glaucoma, and this has been going on for 6 to 8 weeks, and this dog didn't have any other known medical conditions. So here is a hemisection of what I call a representative photo. We did not take a gross photo of this one. I put representative in quotations because there are some differences with this photo and what we saw grossly in this actual globe. So I chose this one just because there is a rather distinct mass in the kind of limbal to more equatorial episcleral tissue. In our particular case, we had said that it was a very well demarcated mass. So in this case, it maybe has some blurred lines. In our case, it was a very discrete mass. Otherwise, we had said the cornea was a little bit cloudy, which perhaps is captured here. And we thought all the intraocular structures grossly look normal, which they look pretty good here as well. So maybe it's a good representative photo. We will move to the histo. This one will be harder for me to show on subgross because it is an extra large slide and I have shaky hands. Focusing's hard. There we go. All right, so same deal. Optic nerve on the bottom. We have our anterior segment up top. Oh my gosh. All right. So our actual intraocular structures do look rather unremarkable, so I probably won't talk about them too much. What I want to focus on is our large mass in the episcleral tissue. It got chunked out during processing, so we kind of lost the core of the mass, which is just an artifact. We can ignore that. There's plenty of diagnostic tissue at the fringes of this mass. But we can see it is rather discrete, so we can see the border. Sorry about the shakiness, everyone. We can see the distinction between mass and normal sclera. Can show how large it is. And again, just kind of normal episcleral tissue over here and mass here, very distinct borders. As we move around, here we go. There is also something happening in the sclera, especially in the posterior aspect of the eye. It's just more blue and busy, so perhaps there is some sort of cellular infiltrate. So as we come over here, everything else looks pretty good at this power. All right. Okay, so again, this is flipped 90 degrees. Now we have that mass kind of on the top of the slide here. We'll just go ahead and dive right in. So here we have our limbus and our episcleral connective tissue. We have this mass here. We'll go one closer. It is made up of a heterogeneous population of cells. So these all look different, not one single cell line here. This is an inflammatory population, not neoplastic, and it is predominantly composed of macrophages. So all of these cells here are macrophages. Let me go one closer. It's kind of hard to see their borders. These are more epithelioid macrophages, so they're not really the distinct round cells that we see with other macrophage populations. But these nuclei are very macrophage-esque. They are oval, sometimes a little indented. They have coarse chromatin and multiple nucleoli. They look like little potatoes to me. Just how I think of macrophages. And they are intermixed with some other cells too. So we have some plasma cells, maybe that's a lymphocyte. We have some neutrophils too. And there are some eosinophils in here as well. They're pretty rare though, so I won't waste our time trying to find them. And in some areas, I can move around. There we go. Those macrophages are surrounding this kind of eosinophilic debris, which is a somewhat consistent finding. Ooh. And in some areas, they kind of get this like whirly appearance and kind of move around, just show them. And see that this is a pretty consistent appearance to this mass throughout. It's just lots of macrophages kind of coalescing, making these indiscrete granulomas surrounding this eosinophilic debris. Here's a really large area. Bunch of it. All right. So this in isolation would be most suggestive of a condition we call NGE, as the clinician suspected, of nodular granulomatous episcleritis, which is an immune-mediated sterile entity directed against some unknown antigen. So the precise etiology for it is somewhat obscure. And typically it does form a very discrete mass, and it's usually very histiocyte heavy. However, we can see other cells as well, other inflammatory cells. So it can be kind of a mixed inflammation. So we have that. As we move into the sclera, there are some other changes to look at. So just starting here, where maybe it's a little less cellular, and we'll find some normal-ish sclera. So here's our normal scleral collagen. I'm going to go one closer. We have these very distinct coarse collagen bundles, and they're interspersed with these flattened mesenchymal cells, so fibroblasts. There is some inflammation here and there, but this collagen looks somewhat unremarkable. As we go to other areas, we start to see changes in the quality of that collagen. So it no longer has that coarse distinction. It's now kind of fragmented, more fibrillar. It's pale eosinophilic. It doesn't really have that distinct eosinophilia that we saw prior. And it just has this kind of smudgy appearance. So this is what we call collagen devitalization. Some say collagen necrosis, which is philosophically speaking, maybe an incorrect term just because collagen was never really a living tissue per se, but a term you might also see. And we can kind of make out those areas here and there of this collagen devitalization. And I go all the way back to the posterior segment. Well, one more. We can see maybe there's a little bit of even an expansion of this posterior sclera. As we go closer, we have more inflammation within the sclera that's kind of similar to that nodule. So just a lot of macrophages, all of these guys, Again, kind of some plasma cells, lymphocytes, neutrophils. This one also, maybe there's an eosinophil right there. I found one. Here and there, a few of them. And they're often surrounding these areas of collagen devitalization. So even here, here's an area where it's really pale and smudgy. We've even lost those fibroblasts that are interspersed with the collagen. So a nice example of collagen devitalization. And it's also on the other side over here. We just have more of it, and it starts to peter out a little bit, but there's still affected collagen as we go more anterior. Rest of this eye is somewhat unremarkable. In the uveal tract, we do have areas where similarly we have this kind of atypical devitalized collagen, mixed inflammation. In our choroid too, that inflammation seems to kind of dip into the stroma here and there, but does not seem to be a primary uviocentric process. This is mostly focused on the sclera. So I'm actually going to go straight to our diagnoses. So I have something for people to look at. So here are two major diagnoses. First one being that eosinophilic or mixed inflammation in the episclera causing an episcleritis and this kind of nodular inflammation, which again in isolation would resemble NGE. But then we also have this process focused on the sclera where we've mixed predominantly granulomatous inflammation as well as scleral collagen devitalization, which is something we most commonly associate with what we call necrotizing scleritis. Has also been called granulomatous scleritis, which is also an immune-mediated condition. It often does also bring in a lot of macrophages. And is also usually paired with scleral collagen devitalization, suggesting that maybe the scleral collagen is kind of the target antigen for this immune-mediated process. In a lot of cases, we kind of see these two conditions, just kind of one or the other, but they both are considered immune-mediated, histiocyte-rich inflammatory processes. So possibly they just represent kind of a spectrum of a similar pathogenesis. So it's kind of an interesting one where we saw these two conditions in the same eye. And maybe there's kind of overlapping features of a similar underlying mechanism. The bottom line for this is that we do strongly suspect this is an immune-mediated etiology. There's no evidence of infectious disease in this case. For at least granulomatous or necrotizing scleritis, that can be a bilateral condition. In this case, they say the other eye is normal, but we just recommend keeping a close watch on that other eye just in case this dog does develop a bilateral manifestation of this immune-mediated disease. So kind of just an interesting case, a weird one that we kind of looked at pretty closely. And that's all I got. Does anyone have any questions, concerns, thoughts? All right.
I wish we had answers.
I know. I think we oftentimes also philosophize about these histiocytic conditions. Right. I think they're very frustrating for us. All right. And I will pass the scope to Dr. Clements.
Okay, I've got two more cases for you. This first one doesn't have a gross photo, as you can see. So this is a 13-year-old spayed female Norwegian forest cat. The eye that we got had conjunctival hyperemia and episcleral injection, chemosis, segmental posterior synechia, a mydriatic pupil that was minimally responsive to light, and complete bullous retinal detachment, and blindness. The patient is also FIV positive, has a history of diarrhea, decreased appetite, and weight loss. So not doing well systemically, potentially. They did do thoracic radiographs and abdominal ultrasound at one point, which showed no significant findings. And the patient was on prednisolone for a little bit of time before this eye was removed and submitted to us, but it ended up not affecting things in terms of our diagnosis. The other eye also has a recent partial bullous retinal detachment. So a lot of things going on in this patient. Right. It's up close. So looking at this eye, in the initial hemi section, there was an area in the cap of the globe that had a little bit more of a mass effect, which I'll show you as well. What kind of quickly stands out is that there are these red spots in the iris, and especially a big one in the ciliary body. little bit more in the iris on the other side. But if we start scanning from low magnification from the subgrowth a little bit further in, there we are. In addition to the red spots, there's also a little bit more purplishness than we typically expect to see. And you can see that increased cellularity around the vessels of scleral venous plexus, here on the other side as well, and kind of through the uveal tract. If we drop in on this area of ciliary body, which kind of seems most interesting, we've got a lot of blood. And it's not necessarily obviously in a blood vessel in the ciliary body, but directly next to it in the iris, a lot of these red spots are revealed as these extremely dilated blood-filled vessels. And then in addition to these dilated blood-filled vessels, the lumen of these vessels contains a ton of abnormal cells. So we have these round cells, which have scant cytoplasm, a high nuclear to cytoplasmic ratio, a nucleus that is typically greater than 2 erythrocyte widths in diameter, and this sort of coarsely clumped fasciculate chromatin, and typically at least one distinct nucleolus. So these are very abnormal looking cells. They are frequently seen packed into blood vessels in this case, maybe sometimes spilling into the uveal stroma. But as we look around in the uvea, it's mostly in the vessel lumens that we're seeing these abnormal cells, which is an interesting feature. We do see them in the vessels of scleral venous plexus, maybe more obviously in on the other side. Hold, please. It's worth noting, just as an aside, while we're doing eye stuff, that even if you see abnormal cells in the vessels of scleral venous plexus, it's difficult to confirm whether that's actual acquisition of a vasoinvasive phenotype, if you will, because sometimes those vessels can be filled with abnormal cells because of passive drainage. The aqueous drains into this vascular system, so some of these cells can make it here passively without necessarily gaining the ability to enter and exit vessels. So be cautious about overinterpreting intravascular abnormal cells in the scleral venous plexus. However, these cells are everywhere in vessels otherwise, so we don't need to equivocate. And then if we take a look at the cap section, which did have more of a grossly visible mass effect, we see a similar change, huge dilated vessels with the addition of these abnormal cells, but also particularly in this level, these abnormal cells are also invading the uveal stroma pretty significantly. This is a really weird case. The top differential in this case was given as lymphoma. So large cell lymphoma, because these round cells have nuclei that typically are greater than 2 erythrocyte widths in diameter. In particular, a differential that could be possible for this case is intravascular lymphoma. So I'm showing this in rounds because it's a really, really, really rare differential. This is not a confirmed case. I've really only seen one confirmed case of intravascular lymphoma in my whole entire life so far, so it is a really rare diagnosis. And this could easily just be lymphoma that's spreading to and or from the eye via the vessels. There is significant uveal stromal invasion in this case. Intravascular lymphoma is a type of lymphoma that proliferates inside the blood vessels. So rather than being like a leukemia where it starts in the bone marrow and circulates in the blood that way, or like a lymphoma that started to spread via the vessels, this is actually like an intravascular population of neoplastic cells. It's a very weird disease process. One of the main things that it causes problems by doing is that it can obstruct vessels and actually lead to kind of multisystemic infarcts in various organ systems. So it can be a big problem. So maybe intravascular lymphoma on our differential for this weirdly distributed case, frequently in blood vessels everywhere. But it could easily just be essentially metastatic or multicentric lymphoma. And those were our top differentials. And may explain findings in the other eye and systemic issues like weight loss and diarrhea. So a bit of a sad case, but also a unusual presentation. So worth showing you once. Any questions about that? We offered IHC, but they didn't take us up on it yet. I don't have any follow-up on the patient. Okay. Then the last case today. We should end with plenty of time. A 7-year-old intact male American bulldog. This patient They say holding eye open, conjunctival hyperemia, 3+ corneal edema, circumferential ciliary flush, dense ciliary flush. Ciliary flush just refers to vessels that extend into the cornea from the periphery at the full 360 degrees of the eye. It sounds like a poker term to me, but anyway. And then the main thing, raised red vascular mass with abnormal raised appearance extending over 70% of the corneal surface from the temporal aspect with only a dorsonasal corneal window visible. And then it also extends into the ventral sclera. The other eye has some uveal cysts, but that's it. And this patient is listed as an outdoor-only dog, which might be significant. So as you can see in the gross view, we got our optic nerve back here. We've got our eyelids coming in here. They were left on the globe. So here's your eyelid margin, for example. And then this is cornea, or cornea that once was. You actually have a clear and normal looking cornea deep, but superficial to mid, there's just this huge mass, tan and red and brown. And it's extending into the conjunctiva and extending a little bit into the episclera here. All right. It's a theme of red polka dots today for these two cases. There, I can do subgross maybe. Here we go. We've got a lot of red spaces and a lot of purple again that make up this big ocular surface mass. And again, just like in the gross image, the deep corneal stroma seems relatively unconcerned amidst the chaos. Here we are. All right. So this neoplasm, and it is a neoplasm, is actually pretty well demarcated. On this side, it's mostly in the cornea, although it's extending ever so slightly into the sclera past the limbus. On the other side, it's extending into the conjunctiva. We actually have a tiny bit of third eyelid coming in here, so it's kind of bulbar and maybe bulbar side of third eyelid extension, and into the episclera, like we saw with the gross view. If we zoom in on this neoplasm where it's still viable, we have anastomosing beams of collagen which delineate dilated, blood-filled aberrant vascular channels and which are lined and infiltrated by a spindle cell population. These spindle neoplastic cells have pretty plump and large nuclei, a coarsely clumped vesiculate chromatin pattern, and typically at least one distinct nucleolus. So again, pretty active cells. I got 15 mitotic figures and 10 high magnification fields. This tumor, if you haven't already guessed, is a hemangiosarcoma. So we've got an ocular surface or corneoconjunctival hemangiosarcoma with a bit of extension into sclera and episclera. Here it is in the sclera on this side. It's got a pretty extensively necrotic superficial aspect. And then in the deep aspect, just showing off how kind of unbothered this cornea is. It's very centered on the superficial to mid cornea in this case. So there's a couple of things that are of interest in this particular eye and worth kind of discussing. One is that they say that this patient is outdoor only. So you'd imagine that this dog catches a good amount of sun. And at least in this extra section, if you drop in, so here's our tumor again, here's our cornea and our iris. If you drop in on the conjunctiva and you go in really close and you worry a lot, as is my wont, there are occasional serpiginous basophilic strands in the conjunctival substantia propria. So there is a little bit of solar elastosis in this case, or actinic damage. This is UV-induced damage. So it implies that there's been chronic UV exposure to the site. A lot of ocular surface tumors, in dogs mostly it's hemangioma or hemangiosarcoma, may be solar-induced. So this patient could have had an initial solar-induced tumor, and that could kind of be part of the pathogenesis here, and or UV radiation may have played some role. So it's worth thinking about that. And another thing that's kind of interesting in this case is kind of the corneocentric distribution. The one thing in this case is that there is significant conjunctival involvement as well. In fact, I didn't reveal it earlier, but this patient had a SNP biopsy or a smaller biopsy earlier on in the conjunctiva that also captured this neoplasm earlier. So this neoplasm probably started in the conjunctiva and extended into the cornea from there. However, it's worth noting that we do occasionally get cases of hemangioma or hemangiosarcoma that is essentially confined to the cornea in our sections, which is weird because the corneal stroma is a relatively avascular structure. So there shouldn't be a lot of corneal or a lot of vascular endothelial cells there to begin with to become neoplastic. It's worth mentioning in this case, even though it may not necessarily apply to this specific individual, that if you see a corneal hemangioma or hemangiosarcoma, it typically implies that there was some sort of vascularizing condition in the cornea to begin with that then eventually became neoplasia. So probably the cornea wasn't right even before the tumor started. And that's kind of all that I wanted to talk about for this case. Fun little bonus. Iridociliary cysts. Just like the other eye they described clinically, these ones probably weren't visible through the front of the eye anymore, but here they are. They're probably clinically incidental for this patient.
Does it have gonio too?
Yeah, right, a bulldog, that's a good point. Bulldogs have potential gonio plus cysts. I don't think so,
Okay.
but I'm gonna only stop at this angle before I embarrass myself on that. Anyway, so there you go. Here's some diagnoses, an abbreviated list. That's it for that case. Any questions? All right, that's it then.
Thanks, everyone. Stop the things.
Right. Let's see. Is it up here? What am I doing? Wait, stop. No, it's right here. Okay, hang on.